Alright, so the topic is chronic disease management, diabetes care coordination, and we'll be performing storyboarding for this. So, firstly, problem selection, lack of interoperable diabetes data across care providers. So, a 45-year-old male with type 2 diabetes receives treatment from multiple providers: a primary care physician, an endocrinologist, and a nutritionist. Each provider uses a different electronic health record system, EHR system. When the endocrinologist adjusts the insulin dosage, this update is not automatically visible to the nutritionist or the primary care physician, leading to inconsistent care and duplicate tests, as well as delayed interventions. Right. So the summary of the problem is that fragmented patient data across multiple state systems. We have fragmented patient data across multiple systems in EHRs. Then manual sharing of glucose readings and medication adjustments, increased risk of medication errors and redundant lab tests, difficulty in longitudinal tracking of patient progress. So the goal for this problem is to implement a FHIR based interoperability solution that allows all providers to share real time diabetes related information in a standardized machine readable format. Now, talking about the relevant FHIR resources that we'll be considering. So, first is resource. So, I've divided it into three columns. First is resource, then the purpose, and also example usage in whatever scenario that we're choosing. So, first is resource. The first resource is patient. Purpose is it stores patient demographic and identifier data. Example usage in the scenario is identifies the diabetic patient. Then we have observation. So, observation is an FHIR resource that would capture the glucose readings and HbA1c uh, HbA1c test results. So, what is HbA1c? It is basically a blood test that measures your average blood sugar levels over the past 2-3 months, right? So, what observation would do is capture the glucose readings and HbA1c test results. Now, example usage: blood glucose level observations are stored using the results. Now, then we have medication request FHIR resource, which represents prescribed medications, right? And for example, we're tracking insulin therapy. Now, the condition FHI resource represents clinical problems or diagnosis. For example, type 2 diabetes diagnosis would be done by a condition FHI resource. Then, practitioner is another FHI resource that would be responsible for identifying the healthcare providers, right? So, for example, practitioners, we have doctors, endocrinologists, nutritionists, right? For the diabetes example. Then, care plan FHI resource defines the patient management plan, and this is basically a structured plan which we'll get. And for this use case, we are monitoring glucose and diet, so we'll get a structured plan for that, a weekly or a daily, uh, plan that is updated uh, in accordance with how the patient is performing, right? Then we have encounter FHI resource, which records each clinical visit, and example is tracks visit to different specialists. Now we have archetype or profiling. So FHIR provides base resources, but for our scenario, we need profiling, that is tailoring the resource to specific clinical needs. For example, custom profile is diabetes observation profile. So we are going to talk about the aspect and their customizations. So first we have profile URL, and this is the URL. Then constraints: category must include vital signs, code limited to allowing codes for blood glucose, value type restricted to quantity, milligrams per deciliter. Now required elements: patient, effective date, time, and value quantity. And optional elements are interpretation and device. Now this is the representation in FHIR in basically JSON format. So you can go through this, right? Outcome or result of this basically implementation is: before the implementation of FHIR, each clinic stores patient data in an isolated silo, that is a non-standardized EHR format, and manual data entry or faxed reports between providers, and no consolidated view of patient progress. But after FHIR implementation, real-time exchange of standardized data through FHIR APIs, all providers can query or subscribe to updates, and improved medication adherence tracking and proactive glucose management. Fewer redundant lab tests that causes lower costs, and better patient safety through updated medication visibility. Now, impact on interoperability. So we have aspect. The first aspect is data format. Pre FHIR, we had proprietary XML or CSV format, but post FHIR, after its implementation, we get standard FHIR JSON format. Then the sharing mechanism: before FHIR was implemented, we had manual or HL7v2 messages, but now after applying FHIR, we have RESTful APIs for FHIR. Now, terminology used in pre FHIR was local codes, but post FHIR, we have global allowing cost nomad CT codes. Integration was difficult in pre FHIR into healthcare systems, but post FHIR, it is seamless between the systems of electronic health records, EHRs. Now, this is a simple diagram. We have primary care EHR FHIR client, which gives the REST API request, get or post. Then it is sent to the FHIR server, which stores patient observation, medication request, all these FHIR resources. Then it's sent to the practitioner, endocrinologist, or the nutritionist on their apps using the electronic health records. Conclusion is This FHIR-based diabetes care coordination model demonstrates how structured standards-based data exchange enables efficient interoperability, data reusability, and coordinated chronic care. By leveraging resources such as observation, care plan, and medication request, healthcare providers gain a real-time, unified view of patient status, ultimately improving clinical